pathway, very famous. So, but one of the most important, that's the ethnic problem, Asian countries. Recently, some Chinese experts prefer to use the CHA2DS2 modified CHA2DS2 score for the Asian country. So in this case, can we apply the modified CHA2DS2 score because it's 59 years old? Yes.
Well, what was proposed as the or mentioned as the modified CHA2DS2 score is if you look at some of the epidemiology and even the trial cohorts, the rate of ischemic stroke was generally higher in Asian compared to non-Asians. And looking through the Taiwan National Insurance databases, what had happened was the risk of stroke starts to rise at age 55 upwards, not 65 as in the original CHA2DS2 score. So even the patients who are, say, a man with atrial fibrillation age 55 to 64 and has no other risk factors, so theoretically, by the conventional CHA2DS2 score has a score of 0, in the Taiwan registries, the rate of ischemic stroke was still 1.5% per year. Now that's above the treatment threshold, 1% per year. So hence the proposal by Dr. Chow and colleagues, and I was a co-author on that paper, that basically rather than giving 1 point to 65 to 74, we should have a modified age range that you get 1 point from age 55 to 74. So in other words, that already fulfills 1 point on the modified CHA2DS2 score. That's important because you can think about this, that if like this lady with multiple risk factors that you mentioned, I mean, that doesn't apply to the modified CHA2DS2 score because of all the other comorbidities you mentioned. But if they don't have any other comorbidities, even if they had an age 55 to 74, if the say that the hypothetical man with atrial fibrillation, age 55 to 64 gets a stroke, you can imagine that that's a category of patients who may well be the breadwinner for the family. And if they're disabled to an AF-related stroke, that could be devastating.
Okay, thank you. How about your idea, Professor Thắng? How about your idea? This case, yeah.
For me, is HAS-split is a score to assess the risk of bleeding when we use the anticoagulation. It's not contrariation. So we can see some item when we score HAS-split score is similar to a CHA2DS2 or CHA score. So for me, if the patient get the stroke, so the patient strongly have indication for anticoagulation if the patient have an AF. So definitely we should go to anticoagulation for this patient. Thank you.
Okay. You agree also? Đồ bắn bù đá, for this case.
See, in my opinion, definitely this patient has indication of anticoagulations because the CHA2DS2 score is quite high. Whereas what we can see in clinical practice is many of our colleagues, they fear about the bleeding. However, the risk, even though some patient has the HAS-split is score around 2, 3, but in reality, some bleeding can be well controlled. I mean, that if you have a gastric bleeding, if you do control well and you do endoscopy, you treat the origin, so it's not there anymore. For patients with the other risk of bleeding is the same. Whereas the risk of, for me, the risk of ischemic stroke, especially in patients with AF and CHA2DS2 is quite evident and obvious. So most of the time we use, but one thing is we will consider the dose of anti-NOx, because for some patients if the HAS-split score is high, we may use low dose like dabigatran 1/10 twice a day, or even some very elderly patients with renal failure, all of issues, even the previous gastrointestinal bleeding. I use the I have used the dabigatran 75 twice a day. It's quite effective, and I mean the patient doesn't suffer any stroke after that. Yeah, this is my opinion.
Okay, thank you. But I think in this case we agree to you. You can use. She can use the NOACs. That's right.
Yeah.
In this case, yes.
Okay, sure.
So we had the second question. An IF patient with arthritis with NOAC has a femoral fracture and requires surgery. So do we need to postpone NOAC periodically? And when will we reuse the NOAC? I think this is a question reserved for Associate Professor Nguyễn Huy Thắng. Yeah, considering about the surgery after reuse the NOAC. You described many data concerning about reuse in some cases, but for this situation, this is a femoral fracture. How long? 30 days or 7 days? Unmute. Unmute microphone. Okay.
Can I read the?
Yeah.
Can I see the question?
Yeah, and aerophilic patient with arthritis with NOACs, he have femoral fracture and requires surgery. So do we need to postpone period of priority? And when we can reuse the NOAC?
Oh, I think it's if you have indication for surgery, if emergency surgery, you have to we can use some. If you use the dabigatran, you can use a Brexpri to result of dabigatran, and you can go to surgery. If you can wait for surgery, is depend what have to stop NOACs before and restart after surgery. This depends on what kind of surgery. Yeah. You can see in the they have a table.
And when you can reuse NOACs after the operation surgery. When you reuse NOACs?
Yeah, I think we depend on what kind of surgery. What kind of surgery?
Femoral fracture. Femoral fracture.
You have to see
a big bone fracture.
You have to see
bone fracture. Yeah.
You have to see again, but I think you need to stop a few days after you can restart again for a few days after surgery.
Yeah. I would like to have your idea, Professor Gregory Leaf.
Well, I think you mentioned a case with regard to femoral hip surgery, and ultimately, again, in terms of starting the NOAC after the surgery, if the surgeon who has done the procedure is happy about hemostasis, then there's a pretty one shouldn't be too delayed afterwards about restarting, because when you start a NOAC afterwards, it acts pretty quickly within a few hours. So there's no sort of, in a sense, fixed number of days. It really depends on how the surgery went, how extensive was it, whether the surgeon who did the procedure is fairly happy about hemostasis post-procedure, and then to make a joint decision about when the anticoagulation restarted.
Yeah. That means it should depend on the decision of the surgeon.
Well, these sort of cases are a combination. So, one thing about NOACs, they act pretty quickly, but certainly if they are left untreated and have no thromboprophylaxis, one could be exposing the patient to a risk of stroke. So, prophylactic subcutaneous heparin alone is not enough as a therapeutic anticoagulation strategy for reducing the risk of stroke. So in atrial fibrillation patients, they are high thrombotic risk, and once the surgeon is happy that post-procedure there is not any great issue about risk of bleeding, then anticoagulation can be restarted.
Because I think he have hip fractures, so he must be embolized long time. So he has the embolism risk in the future. Now in that case, I think the patient must be anticoagulated. During the operation, you can use some anticoagulants as heparin, low weight molecule. And after that, for a long time, when it depends on his recovery time, he can reuse the NOACs, maybe a long time, not only 7 days, but 30 days after, because we see in that case very many risks of the embolism in the future. And how about Dr. Dan?
I think that for the femoral fracture surgery, it could be easier to manage than the other surgery, such as abdominal surgery, because the problem is the question is when we can restart using NOACs. Most of the time, the problem with using NOAC is we know whether it may cause bleeding at our surgery points. And the difficult situation is when patients have abdominal. We have seen cases like that when patients have abdominal surgery and we restart the NOACs, and because the internal bleeding is very discreet, and when we discover that, it's only has the hemorrhagic stroke. Whereas for the femoral surgery, is the hematoma, if it happens, may be well detected, and they may cause compartment syndrome, and at that time we can send back to the surgical room to reoperate to solve the issues. So the question then become much more difficult is when patients have internal, have all the abdominal surgery, and they may, the symptom is not clear. And our doctors, especially those who monitor the patients in the post-op service department, may miss those symptoms, and the time we detect it is already late. Otherwise, from my personal point of view, if patients have femoral surgery, and the surgeons are confident that is the straightforward surgery, and the risk of bleeding or hematoma is quite low, we can restart it very early, just 24 hours after operations. And that's what we have done for our minimal surgery, like putting the pacemaker. We do a well-controlled bleeding, and we reuse the NOACs very early, and so far no problem. We have no problem with that. Thank you.
So, for your experience, when we can reuse the NOAC in this case?
Yeah, 24 hours after operation.
24 hours.
Yeah, 24 hours.
How about you, Professor Grewal? 24 hours is too soon or suitable for the patient? Yeah.
Well, I think I mentioned that before. It does depend on the surgery. It does depend on the surgeon.
Yeah.
So when there's adequate hemostasis and when you restart. But the point I tried to make was that if you do restart, and obviously if the patient can take oral medication, because Dr. Dunn mentioned about abdominal surgery. So it's obviously if the patient can take oral medication as well. But the point I made was that these are drugs that act pretty quickly. So if you're taking a tablet orally, and if there's no contraindication taking oral there will be an anticoagulant effect within a couple of hours, a couple of hours. So, you know, you just have to be sure that that you're not necessarily anticoagulating a patient systemically while there's a potential for bleeding. I don't think there's any fixed rule that it has to be 5 days, 7 days, 30 days. It really, if the patient's AF and has risk factors for stroke, they need to get some anticoagulation on board, whether it's given as therapeutic anticoagulation by heparin, or whether you give the patient as because they cannot take anything orally, or whether you give them back to NOAC.
Thank you. I think otherwise we must balance, do a balance between the risk, and benefit when applied for a certain person, a certain patient. Yes. Okay, so we move on to a very interesting question. Is there a role for genetic pharmacogenetic testing in the future to personalize NOAC therapy? How about you, Professor Gregory? You are an expert concerning about the guidelines,
well,
please.
You got a long story short, and there's some interesting questions coming in the chat Q&A, I'm sure. But in terms of genetic testing, I don't think we're there yet. I mean, some of the large phase 3 trials had a sort of genotyping sub-study, and really they didn't really make a big impact at all with regard to whether or not making a choice on anticoagulant or non-anticoagulation. So at the moment, I don't think we should be too concerned about that aspect.
Yeah. How about in Vietnam? Following Dr. Dan?
We know that in Vietnam the problem is the generic study or the diagnosis test is not yet well developed. I mean, that's not many centers can perform because the cost of the genetic testing is quite high, and I mean it doesn't change much our attitude or our strategy of using the medications afterwards. But however, what we found from the study is I mean there are some patients which have been used NOACs correctly, but still suffer from the stroke events, so ischemic events. So that could be explained by the difference in their genetic system. So that's the genetic or pharmacogenetic testing may play a role here. But whether it could turn into a popular test, or it should be indicated or should be done in big populations, is still unknown, because you know when we make a decision like that, is that we have to take into consideration the cost and the benefit of such testing, and so far it's hard to perform the study to confirm the value of such testing. So I think the genetic or pharmacogenetic testing could I mean that so far is only applicable for some set of patients, not for the general population.
Okay, thank you. I think maybe this purposely in the future phenotyping the anticoagulant patient, treated patient. So the next question, that is a very practical question. Does dabigatran have evidence on VGA prevention for cancer patients? Is the evidence specific to any type of cancer? Professor Deep, please.
In contrast to a couple of the other NOACs, there wasn't any large phase 3 clinical trial specific just for cancer patients, the dabigatran patients. Nonetheless, there have been some observational data how the various NOACs, included dabigatran amongst them, had in relation to managing venous thromboembolism or patients associated with venous thromboembolism with cancer. It's worth highlighting cancer is not a yes/no diagnosis. Some are more prothrombotic than others and more likely to have a propensity to getting thrombosis rather than other. Some of the observational data, they are simply associations, and in relation to the different types of cancer, I think by and large, if they have associated, particularly if they have associated atrial fibrillation, I think it's not unreasonable just to keep them on, and they were taking the dabigatran, I think it's not unreasonable just to keep them on the same therapy, because clearly there's observational data again showing that you are also treating a venous thromboembolism, but at the same time you're treating atrial fibrillation.
I agree with you. In view of the prevention for cancer patients, we have limited data, especially randomized clinical trial, and we can say that it has so strong recommendation on these patients. But we can use dabigatran and vitamin K antagonist for some case, but very take care about some comorbidity in case of cancer, or for example, the liver or the renal insufficiency and gastrointestinal bleeding. So, and that's why we can use it, but we can mostly follow the patient carefully when we use the dabigatran and others, NOACs or VTA prevention. And how about the Dr. Dan?
Yeah, I mean, I totally agree with Professor Lip and Professor Minh. Is so far there's no, I mean, that there's not a single study conducted on this specific population. However, when we take a look into the data of the subgroup of our registry, we can find that there are some populations with the cancers which has earned benefits from using the dabigatran in for VT prevention. The rate of VT is lower in such group, and the risk of bleeding is similar or less than without using the oral anticoagulations. So maybe we need more study about that. But so far, if I mean, the people ask me whether we should use, I think is possible, because there is no contraindication or no evidence shown that using the dabigatran in such patient is could be harmful, or yeah, I think so.
Okay, thank you. For the one question reserved for Dr. Dan. Patients with heart failure due to chronic coronary artery disease, hospitalization or no STEMI, echocardiography with multiple 5 centimeter chamber thrombus. So the patient has a thrombus about 3 multiple 5 centimeter. Left ventricle diameter 65 millimeter. Ejection fraction 35%. So he have a heart failure reduced EF. I would like to ask you how to use anti-thrombotic drugs for the patient in the acute stage and after that. Thank you.
Yeah. Okay. So these patients, we may see these patients quite frequently nowadays, because most of the time when patients have AF, they have usually have morbid coronary artery disease and hospitalized for non-STEMI. So I mean, that in your questions, you mentioned echocardiography with the chamber thrombus. We don't know whether it's the AV thrombus or airway thrombus, but anyway, is the indication for with low EF is indication for using anticoagulation. The question is, I mean, there are still some question needs to be asked, like does this patient have the I mean, have done the PCI or not, and how they use the stent? I mean, things like that. All of that need to be taken into consideration. If the patient was done the PCIs, obviously in the acute stage, at least 1 month after that, we have to use the triple therapy, means the NOACs and together with the dual antiplatelets. However, it's not that simple, because we know that when we use that, patients may develop gastric bleeding or something like that. So everything needs to be taken into account. So it's hard to give you direct answers, but just make it simple. Patients only have no thrombus and no STEMI. So we preferably use the triple NOACs for at least 1 month. And after that, maybe we redo the echo to see how is the thrombus is still there or is it disappear. And based on the Hasblet bleeding, based on the patient's clinical situations, we may decide whether you should use it for a long time, or we may just stop one antiplatelet and use dual therapy, one NOACs together with another antiplatelet.
I think in this patient, he had severe heart failure with reduced ejection fraction. So with a little bit large thrombus.
Mm-hmm.
So normally the oral anticoagulant has some limitation of effectiveness. So what do you think in the future if the thrombus, the persistent of this thrombus, you can do some surgery or ask a surgery for the patient
Mm-hmm.
in the future if the thrombus still persists?
So I mean that's so far there is no study or no guideline telling us that if patients have the chamber thrombus, we need to perform the surgery to take it out. So because the interesting is if the thrombus stay there for a long time, so most of the time it would be an endothelialized. I mean, they stick to the endothelium, and it doesn't move any no more. So that's why no study showed that show the benefit of surgery, or no guideline telling us that we need to perform surgery to take it out. So.
Thank you. How about your idea, Professor Gregory, in this case?
Well,
case. Yeah.
I mean, your question pertains to the use of NOACs or anticoagulant strategy in a patient with LV thrombus, and this is a patient with poor LV function and also had an acute coronary syndrome. And I think Dr. Dunn has summarized it very nicely. There is a position paper from the American Heart Association, position statement from American Heart Association, published at the end of last year, November 2022, which deals with this. There's no large phase 3 clinical trial specifically in LV thrombus patients. There are a number of very small studies as clinical trials which have NOACs available. And then secondly, there's observational cohorts. And whilst some of the initial concerns of physicians, should we use warfarin or should we use NOAC in LV thrombus? Well, I think the general consensus from the AHA position paper is that in most of the patients, a NOAC would be entirely appropriate.
Thank you. A question maybe from a dentist. For tooth extraction of restorative surgery, anticoagulant, how many days? We stop anticoagulant before tooth extraction and restorative surgery. Please, Professor Lee. For dentist extraction, anticoagulant, how many days we can stop the anticoagulant before tooth extraction?
So is that question for me or for Dr. Dunn?
Yeah, maybe he has busy now. Yeah. I think it's a very popular question. It's concerning about what kind of NOAC or anti-vitamin K antagonist. For the antagonist, we must wait a long time, for example, 3 or 4 days. But for us, we can stop and restart early, maybe 24 and 48 hours later. You agree?
Well,
yeah.
Again, to cut a long story short, with a tooth extraction, and obviously this needs liaison with the dentist as well. For most of the NOACs, it's a relatively short half-life. So depending on what is intended, if a simple tooth extraction, maybe stopping the NOAC a couple of days before the actual tooth extraction. The exception may well be with dabigatran because of the renal dependency, and you have to actually check the degree of renal impairment, because it might need to be longer than 1 to 2 days before the tooth extraction. If there's more extensive dental work with multiple extractions, etc., then you're really going to need, probably it goes from a sort of minor to moderate procedure to maybe a high risk procedure if you're going to take a lot of, if you're going to do a dental clearance, for example. And therefore, it may be prudent to stop the anticoagulant for, an extra day or so beyond what you would expect for a simple single tooth extraction. So there needs to be that liaison with the dentist about what is actually planned for the procedure.
How about that? You have somebody more? No?
Yeah, so I would like to contribute my experience, because these questions we receive almost daily, because the most of our patients, they earlier sooner they have the tooth extraction. So the question is nearly the same. So for us, I totally agree with Professor Lip. Is we have to when we decided to stop anticoagulations, we need to take a view at the first what kind of anticoagulations we are using, because dabigatran have short action of duration action, and the other has maybe a longer action. And the other point is what kind of surgery. And we also have to take a look at the renal function, because it plays a very important role in maintaining the effect of anticoagulations. So far, most of the time we just stop like 2 days before the procedure, and we can I tell patients to restart using the NOACs 24 hours after if no bleeding. And fortunately for me, I think the tooth extraction is not a big problem, because most of the bleeding is well controlled. Or if it just keep bleeding, patients may go to the ER and we just do some compression and it could be okay. It's so far it's not a big problem for clinicians like us.
Okay, thank you. So the time is out. We have some conclusion as below. Dear Professor Gregory, dear Associate Professor Nguyễn Nghị Thắng, dear Dr. Đỗ Văn Bửu Đán, and dear delegates, this is very interesting this afternoon, that we can stay before the screen to follow a very important topic that affects millions of people in the world. That is stroke prevention in atrial fibrillation. And after the three presentation and the discussion, we can have some conclusion as below. Patients with atrial fibrillation are still at risk, even when treated with traditional therapies. Thus, ensuring that eligible AF patients receive an appropriate anticoagulant according to assessment of stroke and bleeding risk and patient preference is critically important. The new oral anticoagulants are all safe and effective over warfarin. Balance of anti-thrombotic efficacy and bleeding risk is recognized as essential action. Thanks to the very interesting presentation, which provides us many side views, and to Professor Lip brings info in atrial fibrillation treatment in special population, such as elderly, different BMI, prior gastrointestinal bleeding, and renal impairment. And we can see the prior stroke population would be used DOAC within 48 hours for minor and moderate stroke, as well as the roles of reversal agent. It is impressive and aptly thanks to Associate Professor Tang. And the last, we can see the apply of NOAC in real world through many evidence thanks to Dr. Dan. We are now at the end of the beginning of the new era of anticoagulant for atrial fibrillation and still have much to learn. We have a good time for interesting discussion. Thank you, Doctor, to join us today, and hope that we can see together all of you at the APSC Congress in Vietnam in November this year in Hanoi. Thank you.
Again, thank you very much, Professor Minh. Very nice to see you, Professor Lip. Hope to see you around. Thank you very much.
Thanks, everybody.
Thank you.
Thank you, everybody.
Great session. Thank you.
Bye, everybody.
Bye.